So good afternoon, everybody. This is Kathy Bush, and welcome to the DandleLION Medical Webinar on Supporting and Enhancing NICU Sensory Experiences, a new guideline for implementing consistent, developmentally appropriate, and positive sensory exposures in the NICU. We are really delighted to have Bobbi Pineda today as our faculty. We also have Kathy Randall with us to provide technical support and to assist with answering questions. So a little bit about Bobbi. She is an occupational therapist with Neonatal Therapy National Board Certification. She is an assistant professor at Washington University School of Medicine and has been conducting clinical research in the NICU for more than 10 years. The focus of her work has been on defining factors that impede function while developing interventions to optimize outcomes. She leads the Washington University Neonatal Therapy Research Lab as well. Over the past 5 years, her team has developed and implemented the Supporting and Enhancing NICU Sensory Experiences, or SENSE, intervention in the NICU, and they're currently doing a randomized clinical trial on its efficacy. As a scientist and mother of 3 preterm children, she constantly strives for a better understanding of how to improve outcomes for those who start their lives in the NICU. Welcome, Bobbi, and thank you so much.
Thank you, Kathy, for that introduction, and thank you for the opportunity to be able to share our work that we've been doing for the last 5 years. I do want to acknowledge Joan Smith, who's one of my co-investigators, who isn't able to join us today, but she's been an integral part of this whole project, and I couldn't go without mentioning her name. And then also Mary Rainey was an important contributing author on the parent education. And so I just wanted to acknowledge these members of our team and look forward to sharing our work. So to start, the second and the third trimester of pregnancy is filled with a lot of growth and development. We know that the brain is developing leaps and bounds during this period of time. And then there's also a lot of sensory exposures that preterm infants are exposed to during this time. So there's movement in a fluid environment. They also become increasingly cramped into flexion as they move towards that term equivalent age. There's vestibular stimulation, not only from them being able to move within that buoyant environment, but also from the movement that the mom does as she carries on her day-to-day activities. There's tactile stimulation all around from the uterine wall. The preterm infant's also shielded from light until birth. And then there's also noise and language exposure, but it is buffered by the uterine wall, and so it comes in at low frequencies. And there's increasing support that all of these exposures that are happening in utero are actually timed to help support optimal development, and that they're necessary sensory exposures. There's also lots of growth and maturity over vital body systems that's occurring during this time too. We also know that the brain is undergoing very rapid growth and development. And so one example of this is how cortical folding evolves over the time from preterm birth at 25 weeks all the way up until term equivalent age. So you can see as a 25-weeker, when many of our preemies are born and first admitted into the NICU, the brain is fairly smooth. And then as the baby evolves from 30 weeks to 33 and so forth and so on, the cortex folds in on top of itself, so increasing the amount of cortical area. And so that by the time that they reach term equivalent age, the brain looks nothing like it did as a 25-weeker. And this is all going on really right before our eyes, although can't necessarily see what's going on within the brain. We know that it's happening. And with rapid periods of development, there are windows of opportunity. And so that's where we come in with really what we're trying to do in terms of promoting a more optimal sensory environment. I think one other marked thing about the amount of brain development that's occurring during this time period is that the amount of brain development is more rapid during this time period than it will be at any other point in time in life. And so if you even look at a term control brain compared to the adult brain, you can really see that the drastic changes are really happening during this early period. So while all this rapid brain development is occurring, infants are privy to the NICU environment. And it's very much in opposition to the protected environment within the womb. And brain development is likely very susceptible to these other things that are occurring that really are altered sensory experiences. The NICU has been described as one that's noisy and chaotic and bright. Infants experience painful procedures. They're oftentimes separated from their parents. They also lack the constant movement that they would be receiving if they were still in utero. There's also decreased tactile input compared to the uterine environment, and decreased positioning and flexion. And then within all hospital environments, there's this interrupted sleep that occurs during the NICU hospitalization. So with that, we've really done a good job at really defining practices that can help to support neurodevelopment. In terms of developmental care, trying to reduce the amount of visual exposures, avoiding bright lights, decreasing the amount of auditory exposures. It's more the exception than the rule now to see radios and TVs within the NICU setting, and promoting a healing environment where we really individualize care based on the unique needs of each baby, fostering the parent-child relationship and encouraging things like skin-to-skin care, doing supportive positioning where we nest babies and help them to be able to achieve appropriate flexion to help support development, and then providing support when the infant does have to have painful experiences such as endotracheal intubation or heel sticks, that sort of thing. But it's not all about reduction. Really, the whole idea of positive, developmentally supportive, and appropriately timed sensory exposures can really go a long way in helping to support overall neurodevelopment of preterm infants as they go through hospitalization. In our previous cohorts for infants that were born less than or equal to 30 weeks gestation at birth, the average length of stay is right around 3 months. And 3 months is a pretty significant period of time during a critical period of brain development. And so really trying to optimize the appropriate sensory exposures can have a lifelong impact. Brain development does rely on sensory exposures. It can modify the architecture and the signaling of the brain. Also the development of an abundance of positive, developmentally advantageous synapses can be lied, and that will set the stage for later pruning for specialization. So really early sensory experiences are going to drive appropriate neuronal activity during this critical period and are extremely important for learning, memory, and really the foundations for all later developmental acquisition. So knowing what we know about development within the uterine environment, and then what the NICU environment is like for a preterm infant, coupled with the need to really reduce negative types of exposures, but also promoting those positive ones that are going to help to improve brain development. There's been this recent change in NICU design, and maybe not so recent at this point. I think one of the first private NICU rooms was first described maybe in the early 1990s. But now many hospitals are moving towards the use of private rooms as they renovate their space. And with these, it's really modified the type and the amount of sensory exposures that preterm infants receive during hospitalization. And maybe it's just a little bit of a warning that it's something that we should really pay attention to, because maybe what sensory exposures and things that we did for babies when they're in an open ward could potentially be very different from what we might need to do for babies that are in private rooms. So we set out to better understand the impact of the private NICU room. We first wanted to look at the impact of it on parents. And those findings were published in the Journal of Perinatology in 2012. And what we found is that babies that were hospitalized in the private room compared to the open ward, their parents tended to visit more. On average, they visited 8 hours more per week. However, by term equivalent age, we identified that mothers had heightened stress. And that was a little bit of a surprising finding. We really felt like the private room would be supportive of the family and maybe lead towards less stress. Now in hindsight, maybe it makes a little bit more sense because it also can be a little bit isolating for families. And if parents are in a private room with their infant without these areas of the hospital where they can convene and converse with other families and feel supported, it could potentially lead to increased stress. We then set out to look at the impact of private rooms on infant outcomes. And I forgot to mention that at St. Louis Children's Hospital, which is where we do our research, at the time, half of the rooms are in an open ward style, and then the other half are private NICU rooms. And so the staff is shared across them. The policies are standard across, and it really was an optimal environment to be able to look at these things because we can look at differences in outcomes on infants that are hospitalized concurrently. So when we looked at the impact of private rooms on infant outcomes, we found that infants in private rooms had poor outcome with less organized electrocortical activity by term equivalent age, less hemispheric asymmetry by term age, and poorer language and motor outcomes at age 2 years. And this was also a surprising finding because we, thinking of like trying to reduce stress and improve outcomes, we always thought that really the NICU private room would help to achieve that. So the poorer language outcomes at age 2 years was really a wake-up call to try to pay a little bit more attention to what's going on within the private NICU room that could have potentially been why that happened. So from there, we hypothesized the differences may have been related to diminished language and sound exposure in the private room, and that potentially babies were missing important exposures during a critical period of brain development. I also wanted to just comment that in our NICU, we are in urban St. Louis, so we have high rates of parents with low socioeconomic status and social issues that may have created barriers to them being able to be full participants within the NICU. And so also in hindsight on this study, what we tended to see a lot of are babies that were hospitalized within the NICU private room that didn't have a lot of parent engagement. And so when you have that occurring and staff that are trained to try to reduce stimulation, even noise and sound exposure when they go in to do cares, you have babies that are in a dark and quiet environment. And then when the caregiver goes in every 3 hours to change the diaper and do vitals and cares, and not really engaging with the infant, it tends to be a fairly low sensory environment. And so those findings were published in the Journal of Pediatrics in 2014. There are other findings, however, since this time on the NICU private room. Our friends up at Brown have actually done some great work looking at the differences in open ward compared to private rooms. And they have found that infants cared for in private rooms had greater weight gain, fewer medical procedures, and better attention, as well as less physiological stress, hypertonicity, lethargy, and pain. And one of the starking things that I think from their publication is really looking at factors that could have mediated that. And so they were able to identify that maternal involvement as well as occupational therapy interventions were potentially a mediating factor that led to these positive outcomes. And then more recently, they were able to publish on their longer term outcomes and found that infants cared for in private rooms had better cognitive and language outcomes at 18 to 24 months. And then with that, also found that the private room infants received more breast milk, which could have contributed to those positive outcomes. So different hospitals, St. Louis Children's and then the hospital in Providence really offer, different populations of mother-infant or parent-infant dyads. And with that, I think that it's really important that we pay attention to those differences, because it can help us better understand interventions that can help support the growth and development of infants. And within ours, we're in urban St. Louis with low visitation, and potentially in this other unit, they had higher rates of maternal involvement. So from this study, we found these differences in the single patient room and open ward, which were pretty surprising, and we wanted to then better understand what the sensory environment looked like. And so we looked at auditory exposure, and so we used the language environmental acquisition device. It's a little recorder that's about the size of a box of crayons. We could put it in at the baby's bed space, and it measures the amount of sensory or auditory exposure that the baby is getting. And then you take it upstairs and you plug it into the computer, and it spits out quantifications of the amount of time that they had ambient noise, how much time they had meaningful language where someone was talking very close to them, distant language, the amount of electronic sounds. It also gives a word count of the number of words that were spoken in and around the infant within a 16-hour period. And then we're able to look at differences across the two environments. And what we found is that there was, in fact, more silence in the private room and more noise in the open ward that reached statistical significance. And by term equivalent age, that difference was almost 3 hours, 3 hours more silence in the private room compared to the open ward, which could have potentially explained our previous findings. So those findings were published in the journal Pediatrics in 2017. So this previous work really helped us identify that we have a critical period of development that's unfolding within the NICU. The changes in NICU design result in changes in positive and negative forms of sensory exposure, and that we really wanted to try to find out ways that we could implement positive evidence-based sensory exposures that could be important for improving a neurodevelopmental outcome. However, those exposures really needed to be properly timed, individualized, and then consistently delivered. And that's what we then set out to do. One big point of discussion prior to launching into this next stage, however, was whether we really focus on auditory exposure, because it appeared that, looking at the differences between open ward and private room, it was probably largely auditory that could have contributed to those later language outcomes. Or if we wanted to expand it to look more at multimodal exposure. And we did end up going with the latter, largely because it's really hard to just isolate one sensory exposure. Most interactions occur in a multimodal fashion, as when a mother holds her baby. She's not just giving the baby tactile input, she's usually giving them auditory exposure with her voice. She's gently rocking, so she's giving vestibular. The baby can smell her scent, and so the baby's getting olfactory. And so most of these exposures do happen in a multimodal fashion. So we decided that we wanted to better capture what sorts of multimodal sensory exposures would be good for promoting optimal development. Another important consideration was just how the development of the senses occur. We know from previous literature that the tactile system is one of the first ones to develop, with visual occurring as the last one. And so likely the appropriate types of exposures would vary across post-menstrual age based not only on the immaturity of the infant, but also on the type of exposure that is being administered. So looking at appropriate sensory exposures, one of the first things that we really needed to do was to find out what the literature tells us in terms of appropriate sensory exposures within the NICU setting for preterm infants. So we searched electronic databases for evidence, Medline, CINAHL, Cochrane Database, Google Scholar. We also hand searched all the reference lists of articles that had to do with appropriate sensory exposures for preterm infants. We were looking specifically for studies that impose a quantifiable environmental sensory exposure or therapeutic intervention during the NICU stay. All of the studies had to be published within the last 20 years. We only took English-only articles, And it had to include infants that were specifically hospitalized in a level 2, 3, or 4 NICU. And we also looked specifically for studies that did these interventions on not just a low-risk sample. So some articles, they specifically pick or cherry pick a low-risk sample, like, you know, the babies that are breastfed, have never been on medications, were never intubated. And we felt pretty strongly that we wanted to not do that when we were looking for literature, because the reality within a level 4 NICU is that we don't get to cherry pick, that we do have the babies with the grade 4 IVHs and the babies that are intubated for long periods of time and have been on multiple different kinds of medications and so forth and so on. So we really wanted interventions that were appropriate for a very high-risk sample. So our population were infants less than or equal to 32 weeks gestation. All the interventions had to commence prior to 36 weeks post-menstrual age, and specifically had to do with a sensory exposure or sensory stimulation. There also had to be a comparison group, and we were looking specifically for articles that had outcomes related to behavioral outcome, physiology, because that's tied into development, especially according to the synactive theory, and then also things that had to do with maternal mental health. And then you can see some of the keywords that were used during this review on the right-hand side of the screen. So we did find a lot of articles. So for Tactile specifically, we found 31 different articles, most of which had to do with skin-to-skin care or kangaroo. Also some on gentle human touch and massage, and one on acupressure. In terms of auditory interventions, we found articles largely that had to do with live music, also some on recorded maternal voice. And then you can see there's a smattering also of live singing, biological sounds, and then music. We also looked at articles that had to do with multimodal interventions. And this would be where one or more sensory exposures were done at a time. And so the ATVV was, you know, some of the studies, they had the most studies within this multimodal capture, with the exception of massage. And I know that massage shows up in 2 different places, both in Tactile as well as multimodal, because there's different ways that you can do massage, one of which includes a kinesthetic component. And so when it included that kinesthetic component, it got thrown into this multimodal category rather than the Tactile one. Then in terms of visual interventions, there were no studies that actually looked at visual stimulation, like holding up target cards or holding things in close proximity to the infant's visual field. Instead, really all the visual interventions had to do with the light environment. And so most of them had to do with cycled lighting, with the literature really supporting cycled lighting over dim or continuous light. And then in terms of kinesthetic interventions, the interventions largely described had to do with physical therapy. All of the outcomes within this domain had to do with bone, so bone mineral density, bone health. So not necessarily having to do with outcome related to development, but really bones. And then there were 3 articles that had to do with olfactory and gustatory, one on mother scent, one on breast milk odor, and then on one on oropharyngeal colostrum. And the colostrum was not for nutritive or lining the gastrointestinal tract, but it was really done more of as a sensory exposure, which is why it was included within the study. So one of the things that we found with this review, there were 88 articles that we identified on sensory exposures, is that the amount of different things that were done was pretty extraordinary. All of the outcomes were different, which made it really hard to combine them into having a cohesive understanding about any one thing. Many of them were done for very short periods of time. In fact, one article, the sensory exposure was done for only 45 seconds, and then the outcome measured. Others went on for a little bit longer, but most of them probably fell within like a couple of days of a sensory exposure and then looking at the outcome. And this also lended towards really wanting to have a better understanding of what would have been the impact if they had done it for longer, or they had done it over the entire course of their hospitalization. The other thing that was very, very different across studies is when they did the intervention. So some studies, it was really, really hard to pinpoint when exactly they did the intervention. And then for others, they did describe. So for example, this table identifies where the literature is in terms of when the intervention was done across post-menstrual age. So if you look under tactile interventions for gentle human touch, there's literature starting at 27 weeks post-menstrual age all the way up to 37 weeks. Whereas massage, the literature starts at 31 weeks. The green is going to indicate that there were positive findings related to outcome from that literature. And then if there were questionable findings, there's a little tad bit of yellow. And then if there were negative findings related to the intervention at that post-menstrual age, there's red. So you can see a little smattering of yellow and red, largely in the skin-to-skin care or kangaroo care. And this is because literature does exist, or did exist at the time that this was done, from 24 weeks to 29 weeks post-menstrual age, and then again from 31 weeks all the way up to 40. So positive outcomes related to it. But there were some negative outcomes, largely related to temperature regulation, especially in those earlier periods. And so that's why that's identified that way. You can also see under auditory interventions that live or recorded music starting at 25 weeks has been identified within the literature. Cycled light starting at 23 up to 36, but also knowing that cycled light protocols really you don't start cycling until 32 weeks. Kinesthetic starting at 30, maternal scent and breast milk starting at 31, colostrum starting at 24, ATVV, those articles had to do with starting the intervention around 33 weeks post-menstrual age. Massage therapy as early as 28 weeks post-menstrual age. And you can kind of see how things kind of got grouped along the way from this, this integrative review of 88 articles. And so with that, we've then tried to come up with an intervention that's appropriate based on the evidence across post-menstrual age to have a better understanding. So one of the big questions that we get asked a lot is, so what? So, we're looking at kangaroo care, we're looking at massage, we're looking at gentle human touch. And, the big thing that we get from everyone is, well, so what? Because we're already doing all of that. We do that in our unit, we're pretty active. But then when you really boil it down and you ask them more pointed questions, like, okay, so you do skin to skin. So when was the last time that you did skin to skin care with that mom? And you point to someone specifically, usually the answer changes. Oh, well, I did it like 2 weeks ago we did it, or a week ago, or 5 days ago. And when you really boil down to, are you doing these things every single day of hospitalization to be able to give the baby the maximum benefit of positive exposures, that it's really not being implemented in that fashion. And really that's what we've set out to do, is really try to come up with appropriate timing that you can do these positive evidence-based sensory exposures, how you can do them in conjunction with other interventions, usually medical interventions that are occurring at the same time. And then really at what dosage. So how much is too little and how much is too much? And what is developmentally appropriate at greater than 35 weeks compared to if you have a baby at 24 weeks post-menstrual age. So there's several steps that we undertook to really be able to define age-appropriate sensory interventions for preterm infants. And the first one, which we just described, was really looking at the current evidence. Those findings have been published in the Journal of Perinatology in 2017. We then set out to get perceptions from parents. We had interdisciplinary focus groups. We also did a pilot study of the intervention, and then are currently doing the randomized clinical trial. So I'll describe a little bit about the parent groups and the focus groups and the expert opinion and where we are in this whole process. So the first thing that we set out to do after the integrative review is to get expert opinion. So we did a couple of workshops, one at Graven's Conference on the Physical and Developmental Environment of the High-Risk Infant. That was in February of 2015, where we had 63 healthcare professionals join our group and give some really important insights. We also did a 1-hour webinar with the National Association of Neonatal Therapists. And then that was, so difference being that Graven's, we had neonatologists and social workers, as well as therapists and nurses, whereas the NICU conference, it was largely made up of OTs, PTs, and speech-language pathologists. And so some of the key findings that we found related to tactile exposure is that touch, holding, and skin-to-skin care are the most common tactile interventions, and that most people start them around 24 weeks post-menstrual age. People do tend to use positive tactile exposures during mechanical ventilation and CPAP. Some people use it during oscillatory ventilation, and then even some also use it during ECMO. In terms of auditory interventions, recorded music was the most common auditory intervention. Most start to use it around 33 to 34 weeks. Most people do it during CPAP and CIPAP, and still some people said that they use it during ECMO and oscillatory ventilation. In terms of multimodal exposures, most do skin-to-skin care, kangaroo care, and most start doing that around 30 weeks post-menstrual age, with some reporting that they start as early as 24 weeks. And then multimodal interventions are done by most people during mechanical ventilation and CPAP or CIPAP, but few reported that they used it during ECMO and oscillatory ventilation. And then in terms of vestibular, most people reported that they do rocking and infant swings within the NICU starting at 30 weeks post-menstrual age. Most do not do vestibular stimulation when on medical support, with the exception of it being done on CPAP and CIPAP. Also, most reported that it's really done mostly by nurses, but it also can be done by parents and therapists. In terms of visual exposures, most used dim light, with some doing cycled lighting and then some alternating between bright and dim, but on no specific schedule, such as in cycled lighting. And most start doing careful attention to the visual environment starting at 36 weeks post-menstrual age. In terms of kinesthetic interventions, most reported that they use physical therapy and occupational therapy within the NICU setting starting at 27 weeks post-menstrual age. Most reported that they do it when they do these services when the infant is intubated and on CPAP and CIPAP, with fewer doing such interventions when babies are on ECMO or oscillatory ventilation. We then set out to better understand parents' views of sensory-based interventions. And so we interviewed 20 parents of preterm infants who were born less than or equal to 32 weeks. We did a phone interview with them within 8 months of infant discharge, and then we used scripted questions to better understand what sorts of sensory interventions they used, and then also what their perceptions would be if we were to implement something like the sense intervention. What we found from our parents is that the majority of mothers reported kangaroo care as their favorite and most common sensory-based experience with their infants in the NICU. Most were introduced by nurses to holding their infant the very first time that they went into the NICU. The majority of mothers reported that nurses, therapists, and other staff were extremely helpful in allowing them to do sensory-based experiences with their infant. And then a couple did report that privacy and noise levels in the open bay prevented them from doing as much of it as they wanted to, and that some nurses were not quite as helpful in allowing them to do everything that they wanted to do with their infants. So with that, the evidence that we were able to gather, the expert opinion, the parent reports, the workshops, and then also having a couple of multidisciplinary focus groups at Children's with our own team, we were able to identify appropriate doses of exposures in terms of tactile, auditory, visual, vestibular, kinesthetic, and olfactory. And you can see that these are really, it goes back to what the evidence is. So our tactile exposures are going to be kangaroo care, holding, and gentle human touch. And then they range based on the baby's postmenstrual age, anywhere from 1 hour to 3 hours per day. For auditory, it's talking to, reading, or singing to the baby. Music can be used starting at 32 weeks postmenstrual age. Auditory exposures should be done at 45 decibels, so that's really a whisper or a quiet conversation, such that it really shouldn't disrupt the infant from sleep if they're sleeping. And then the range is anywhere from just having quiet conversations around the bed space, which would be like your really early babies, 25 weeks, 26 weeks, all the way up to 3 hours per day on the babies that are getting closer to discharge. In terms of visual exposures, the cycled light is part of the sense intervention, and that's where you have a dark environment until approximately 32 weeks postmenstrual age. We also went on to further clarify that it really should be less than 10 lux, which is the measurement of light within the unit. And then using cycled light starting at 32 weeks. And then so this is where you go from a dark environment to a lighter environment, but also wanting to really still keep those light levels fairly low. And so the light environment being 25 to 100 lux. I'm going to skip over kinesthetic, and I'll come back to that in just a second, because that one requires a little bit of additional explanation. In terms of vestibular stimulation, there's not a lot of evidence on vestibular. In fact, there's no articles that just look at vestibular independent of others, although it is included in the multimodal intervention of the ATVV. However, infants do get a lot of vestibular stimulation when they're in utero, and likely it's a really, really important and powerful sensory exposure. And so in taking all of the evidence and trying to come up with best practice based on what we know, we suggest gentle rocking while holding, and this is really done largely at the later postmenstrual ages, up to 7 minutes per day. And then olfactory, using a scent cloth under the baby's head until 32 weeks postmenstrual age. And then, before that, as well as after, encouraging holding and close contact with the parents. And then going back to kinesthetic, the recommendation within the sense intervention is to have unrestricted movement opportunity for 2 minutes prior to a diaper change. And this can range anywhere from 1 time per day up to every time you do cares or a diaper change. So the kinesthetic intervention was also another challenging one to really describe. The literature really supports those physical therapy interventions that have to do more with bone mineral density versus developmental outcome. But there's really been an increased focus on Prechtel's general movement assessment and what quality of movement should look like. And when you really boil down his amazing work, what we know is that there are these movement patterns that come from central pattern generators deep within the brain that are automatic. You can see them under under ultrasound prior to babies being born. You can see them right after birth. You can see them in the NICU. You can see them up to 4 months of age, although the type of movement will change as they go through corrected age after their NICU stay. But movements are really, they come from these central pattern generators deep within the brain. They're normal. And what happens is when we try to bunt babies up into nice flexed patterns, which we also believe to be really important, we could potentially be stifling that normal movement that's supposed to be occurring. And so really wanting to give them some level of an opportunity to have these unrestricted movements. And so in support of Prechtel's work, giving them 2 minutes prior to a diaper change. So this amounts to unswaddling the baby right before you're going to do a diaper change, allowing them to have unrestricted movement, and getting your supplies together, and then coming back and giving them support to finish out the diaper change. The sense intervention is also was developed to be done by parents. And so we recognize that parents are the most important person in an infant's life. And by having them really be able to engage in care and do sensory interventions that can promote optimal development, we could potentially be improving outcomes not only for the infants, but also for the parents themselves. So education and empowerment is a huge part of the sense intervention. And so now I'm going to dive into the actual parent education materials. I'm going to fly through these slides and just slow down on a couple of them just to show some important points, and then hopefully it'll just give you an overview of the sorts of materials that we use for the sense education. But this is the actual guidebook that we use for parents. We use it in a written form, so we have one that's available at the parent's bed space and in a binder, and then because a lot of them wanted to take them home, we also make them another one that they can actually take home with them. But it contains really all of the supportive information of why the sense intervention is important, and then also how-tos on how you do all of these things and exactly how much you should do at what postmenstrual age. So first there's a table of contents. And so you can see we have meet the team so that they can know some of the people that are going to be coming in and out that have to do with the sense intervention. We talk about parenting in the NICU and what they can do for their baby. And then it gets into sensory development and how the baby experiences the world and how the senses are so important for learning and memory. And then we talk about growing up in the NICU and how maybe the sensory environment might be different. And then how the baby talks to them. So this is going to get all into how they can read their infant's cues and respond to them appropriately. And then by chapter 6, we talk week by week across each week of hospitalization what the actual dose and timing of appropriate sensory exposure should be. And then chapter 7 will have a how-to guide. So it'll specifically give them information on how to do massage and how to do a stand transfer for skin-to-skin care. So the first thing that we have within our booklet is, just congratulating them on their baby and understanding that it can be a roller coaster ride, trying to give them terms too that we're going to be using throughout the book so that they understand the difference between gestational age, being the age that the baby was born, and then post-menstrual age, which is really going to tell us where along that developmental trajectory until term equivalent age their baby is. And then we have information about our team so that they can understand. They have pictures of the different team members and a little bit about their background and then what they're going to be doing as part of the study. We have a research coordinator, and then we have two occupational therapists and a physical therapist that function as our sense administrators for our study. And then we also have research assistants that come in and change out bedside logs and make sure that parents have any kind of equipment that they might need in order to be able to maximize their involvement within the NICU environment and doing these interventions with their baby. We also have a parent advisory team. They were key really in our early, in the early stages of development, because they made sure that all of our materials for parents were on a 5th grade reading level that could be understood by parents across all different kinds of backgrounds, and that it contained things that maybe wouldn't be alarming or hurtful to them. So they were really great at, making sure that they were appropriate for parents. We also had identified a sensory support team, and so the sensory support team fills in the gaps in terms of the dosage of sensory exposure when the parents cannot. So I think I mentioned a little bit earlier with our previous work that we're in urban St. Louis. Not all of our parents can or will fully engage, and so we wanted to make sure that those babies of those parents still receive appropriate positive sensory exposures across hospitalization. So the first thing that we try to do is really get the parents to engage and do it, and so that's why we enroll extremely early, we educate very early, and we try to encourage them But then when they don't come in and do the sensory exposures, this team will come and fill in. So for us specifically, we use OT graduate students at Washington University. They all underwent 12 to 20 hours of education and training to do positive sensory exposures within the NICU. And other units can potentially use volunteers or cuddlers, different sorts of there's other opportunities for you might use as a sensory support team, but OT students are just what we have tended to use. Then the next chapter is on parenting in the NICU. So again, just focusing on that the parent is the most important person in the baby's life. We talk about how they can kind of be that stable part in an unstable situation, and that what they do with their baby can have a lifelong impact. We also talk about sleep and how they can do things to help support their baby's sleep, and how they can identify when their baby is overwhelmed and to help to support them. And then the next chapter is on experiencing the world and the senses. And so we talk about tactile, auditory, vestibular, kinesthetic, all the different senses that really help children and adults too understand the world around them, and that these are really building blocks for later function. We talk about how babies get certain sensory exposures within the womb prior to a full-term birth. The tactile exposure from the uterine wall, the movement that's occurring, what kinds of smells and tastes they experience, how they hear and see, and how these all help to support optimal sensory development. But then we talk about how the NICU environment is different, and then what sorts of things they can do to help to support their baby during their NICU hospitalization. We also talk not just about things that they can actually do to the infant, but also things that are related to reduction. And so trying to keep noxious smells out of the baby's environment, trying to reduce the amount of smell of smoke on parents as they do these interventions, also shielding direct light from the baby, that sort of thing. And then the sense of smell and hearing, what sorts of things they can do to help to support the baby's auditory system. And then sight. And then chapter 5 will talk all about the baby's cues. So these probably look familiar, talking about like what it means when a baby shows foot bracing and sucking movements and hand clasping or finger grasping, and how they can show that they're ready to interact, and what sorts of things they will show if they're stressed or need support. And then we get into the week-by-week guide and by chapter 6. And so this is really the nuts and bolts of the intervention itself. Prior to that, it's really just the background information. It is extremely important that parents and healthcare professionals understand how to read infant cues and respond appropriately to them as they're doing any kind of intervention within the NICU. And also, just what the basis is for doing these sorts of things. But the week-by-week sensory plan is going to give the actual dose and timing for each of the exposures across time. So we have it labeled where there's different icons to show you which one we're talking about. So first there's touch, then hearing, then smell, then seeing, and then movement and body is put together. And so you can see that at 23 to 27 weeks, the amount of sensory exposures within the guideline will be extremely different from how it will look later on. And so here are some things you can do with your baby each day this week. So you can see that they can do skin-to-skin care or comforting touch with the baby for at least 1 hour per day. So that's the dosage, is a minimum of 1 hour per day of these things. For auditory, keeping the area near the baby quiet, but engaging in soft conversations near the bedside and during diaper changes. Using a scent cloth for olfactory. And then at 23 to 27 weeks, the lights really should be off. We should be at less than 10 lux. And then giving them one opportunity for the movement opportunity or kinesthetic for 2 minutes during a diaper change. And then you'll be able to see that it's going to continue to evolve. So then by 32 to 33 weeks, for tactile, it's providing at least 2 hours of positive touch each day by doing one or more of these. And so by then you have babies that are able to regulate their temperature a little bit better so they can be held in a blanket. They also can tolerate having massage 1 time per day. They can tolerate kangaroo care. And then for auditory, providing a minimum of 1.5 hours of positive sound each day. At 32 weeks, you can introduce music too. So it can be reading, singing, or speaking to the baby, but also playing soft or recorded music. You're still using a scent cloth, but also encouraging close maternal and paternal contact. And then by this age, we should be doing cycled lighting. And so 12 hours of lights on and 12 hours of lights off, but paying close attention to it not being too bright during the light on times. And then unswaddling the baby and giving them an opportunity for the movement opportunity for 2 minutes, at least 3 times per day. And then rocking is also introduced for 2 to 3 minutes. And then you can see by 36 weeks, the baby should be getting even more. So at least 3 hours of positive touch each day. There's different opportunities that the parent can basically choose what they want to do in terms of this positive touch. A minimum of 3 hours of positive sound. Holding the baby often, using cycled lighting, and then unswaddling basically during every diaper change at that point, and then doing rocking for at least 7 minutes. One thing that was a nice point of discovery for us is that we quickly realized that infants, like, it's a lot of exposure. So up to 3 hours per day of auditory and up to 3 hours of, auditory and tactile. That's a lot. It's really not a problem when you have infants that are orally feeding at that age because they come out of the bed, they're being held and engaged with, and those things seem to just sort of happen naturally. But the issue is really when you have those babies that maybe aren't orally feeding yet and then spend a lot of time in bed. But developmentally, they're still close to term equivalent age. So it is kind of a nice way to just be reminded that if they're not orally feeding, that they may need these additional exposures. For chapter 7, we get into the how-to guide. So talking about kangaroo care and how you can do a stand transfer, how you do positive touch and massage and the movement opportunity and rocking, and scent and give sound, and how you do cycled lighting. And those are all within the parent education materials. We also have an electronic version that we use with our families. And so within it, you can push it to an iPad or to a PC or even to their iPhone, and then they can click it and open up a video, and the video shows them basically how to do these things rather than them having to read it. And then it just finishes with a poem for families. And during our implementation of the sense intervention, I could probably talk for another hour or two on just implementation of sense, because every unit is different. Every NICU has its own culture, and there were a lot of things that we had to overcome. One was our comfort level with the sensory support team. Even though we used OT graduate students, it was hard to let go, and also to figure out what they can and they can't do as OT students. And, we had to come down to what we felt comfortable with. And so for us, it was to not allow them to do holding. So when they go down, they could read and sing and talk to the baby. They can play music, and they can do gentle human touch within the bed space, but we do not allow them to hold. That just seemed to cross the threshold in terms of our comfort level. This is also in contrast to our volunteers for the hospital who do come in and do holding. So it may be somewhere where we can stretch to go in the future, but at this point we decided not to do that. We also had to overcome barriers related to not bumping into parents. We wanted to make sure that babies were getting their sensory exposures, but we really want parents to engage. And so by going in and checking on them continuously and bumping into them, we potentially could have like shown them in the early phases that we didn't have confidence in them fulfilling or doing these interventions with their baby. And so we had to get better at kind of like timing, like giving, having faith that they were going to go ahead and do it, and then maybe filling in when they could not, rather than sending people down ahead of time. Also individualizing based on the medical status. Most of these interventions are fairly benign. There are individual situations where infants can't tolerate really anything, even gentle human touch, even auditory exposure, although those are more the exceptions than the rule. But we had to get comfortable and figure out ways that we could modify the intervention when it really just couldn't happen. We also had to really be okay with infants being randomized to standard of care, and in all honesty, we still struggle with this. In fact, this week we enrolled 2 babies that got randomized to the control group, and it's just like, you know, because we really want them to get the sense intervention. But standard of care is not a horrible place to be either. You know, our standard of care in our unit, there are wonderful nurses and therapists and people who support these parents in doing kangaroo care and these other things with the babies. It just doesn't fall within that specific sense guideline. We also really had to work out issues related to the timing of interventions. And we struggled with this because, you know, just based on training, we're in the mindset of clustering care and allowing this long period of uninterrupted sleep, and then maybe doing the interventions right before they're going to have their next care time. And then this became hard because, of course, other people are wanting to get in and see the baby during that time period. But also, many of these interventions actually do help to promote sleep. And so we had to do a little bit of discovery with that. When you're doing gentle human touch and supporting these infants, that actually can be done at any point, especially if a baby is having a long period of irritability and having trouble soothing themselves and going off to sleep, that in fact the intervention would be ideal to occur at that time. So we had to work out some issues with that. And then just really remembering the context of daily life activities as well. I mentioned a little bit earlier that when a baby is orally feeding, these things are happening as a natural progression of their engagement in feeding. And so it doesn't mean that you have to do sensory interventions above and beyond those, that those then become the sensory interventions that they need. So then we, once we got all of these things worked out, we did do a pilot study. So we enrolled 30 infants. We initially intended to enroll 10, but it quickly expanded because we realized that we needed to have a little bit more discovery. These babies were enrolled at birth. They had parent education and were encouraged to engage in doing the sensory-based interventions. The sensory support team did fill in the gaps, and then we continued to modify the intervention as we figured things out and had some discovery. And at that point, we were developing the written education as well as the electronic version of the materials. We did do some preliminary analysis on this pilot study, and we took a previous control group that was enrolled prior to the implementation compared to the babies that got the sense intervention. And one nice thing that we found is that maternal confidence in our sense group did reach statistical significance. So parents did seem to have more confidence, which was a cool finding. And then currently we're doing a randomized clinical trial. So this we started in August of 2017. We have enrolled 68 out of 70 preterm infants born less than or equal to 32 weeks. All of them are hospitalized in the private rooms. We do still have some open ward rooms that are in our NICU, but we do not recruit out of those because we wanted to try to keep the amount of sensory exposure standard across all of our babies. These babies are also free from congenital anomalies and enrolled by day of life 7. They're randomized to one of 2 levels of sensory exposure, so the sense or to traditional or standard of care. And I think I described those a little bit earlier. And then we have multiple different outcomes that we're looking at. So at term equivalent age, we're looking at early neurobehavior using the NICU Network Neurobehavioral Scale, the Dubowitz, and the General Movement Assessment. We're also looking at sensory processing using the sensory profile too. We do multiple different measures of maternal mental health to see if we might be making an impact on parents. So we use a parental stressor index, the Edinburgh postnatal depression scale, the state trait anxiety inventory. We also do the PPQ to look at PTSD, the MCQ to look at confidence, and then there's also some other measures of self-efficacy in there as well. And then we're also measuring mother-infant interaction using the NCAST. And then we will follow up with this group at 1 year of age with a ASQ, the Ages and Stages questionnaire. We'll do the sensory profile again at that age. We'll also look at maternal mental health at this 1 year corrected age, and then do a measurement of the home environment so we can hopefully correct for some of those things that might be dictated by the environment at home. So to wrap up, in terms of environmental modifications, we do hope to reduce aversive stimuli with a sense guideline, reduce noxious sensory exposures, but ultimately provide positive forms of sensory exposures that are all rooted in the evidence, known to improve developmental outcome, and then also to engage the parents for a lifelong impact. So stay tuned. Late in 2018, hopefully we'll have the results of the randomized clinical trial and we can comment further on them. And where we're heading from here is finishing out this RCT and then hopefully doing some more implementation across other sites. Currently, we have made available, as of a month ago, the sense intervention to other hospitals. It is available at cost. We consider it to be best practice, but also just, full disclosure that it is undergoing trialing currently. There may be additional discoveries within the next couple of months that may lead to additional modifications as we have that discovery. But we do hope to establish some future collaborations with other hospitals and maybe learn a little bit more about how it has to be adapted for implementation across other sites that have a different NICU culture. And hopefully all of this will lead into future grant funding where we can support multi-center trialing. And then what is needed in order to implement SENSE is really having a SENSE administrator, so having dedicated staff to oversee the program. Luckily, most level 3s and 4s have a physical or an occupational therapist on staff, and they may be perfectly suited to be that SENSE administrator. Also, nurses maybe who have a dedicated role to be able to help improve parents being engaged within the NICU could also be a SENSE administrator. But the SENSE administrator does the initial education and then updates the family each week. They also oversee the sensory support team if one's used, and they do the infant assessments each week just to make sure that the infant can in fact tolerate the guideline as it's defined. Also, we need parents, because parents are the most important part of the SENSE intervention. And then, while not necessary, a sensory support team can be considered to fill in gaps, especially in areas that have families with a lot of social risk. And then ultimately just needing a commitment to working toward a culture to support the sensory environment in the NICU every single day of hospitalization. So not allowing it to kind of evolve as it will, but really a commitment to every single day. And then I just want to thank our Washington University Neonatal Therapy Lab. We have a great team that has really helped all of this to be possible. It's not possible without the infants and families who participate in our research. And also all the healthcare professionals who really helped us along the way, giving us expert opinion and being part of our focus group so that this SENSE intervention could be developed. And then thank you to all of you for being here.
Thank you, Bobbi. That was really a lot of information packed in there. We could have definitely gone on for another hour, but thank you so much for trying to share as much as you could. We already have some questions in the queue. So Kathy Randall, do you want to start off?
Sure. Absolutely. I think probably the most pressing questions that people are going to have, if you guys haven't already put your question in the Q&A area, feel free to do it there. I'll be reading them out. And then any of the questions we don't have a chance to get to, we'll address a different way, but we'll try to just keep going. And those of you who have to go, please feel free to do so. So I guess probably the question will be, Bobbi, for people is, if they're interested in being one of your site collaborators, how should they keep tabs on this? Should we add something to our resource page that has maybe a link to some sort of form for you? Like, what do you think is going to be the most reasonable way after thousands of people view this?
So probably it would be best if you just send an email. So we have this email, and I think it's on the one-page handout, if I'm not mistaken.
Okay.
If you want to just send an email that you're interested in potentially being one of the multi-sites as we move that direction, then I can reach out when we're ready for it.
Great. Okay, fantastic. I know that's going to be somebody's going to ask about that. So someone asked about, what are your suggestions for babies who don't tolerate being unwrapped? So those jittery babies, and that, you know, they really seem stressed out by that lack of containment. What are your suggestions, or what have you learned already about those babies, and what do you do?
Yeah, that's a great question. So the movement opportunity is really just 2 minutes of unrestricted movement. But there is a little caveat to that, because it is agreed there are some babies who, you know, not just jittery, but it throws them into like startle after startle after startle, or they just don't tolerate it, right? And so I think the healthcare professional just has to make a judgment when that happens, and then provide whatever support it is. So maybe it's that the unrestricted movement still occurs within nesting. So they're not swaddled real tightly, they have some movement, but it's still within the nest. Or it might mean that they only allow free movement of the legs, and then they switch, and then they do free movement of the arms for the second 1 minute period. They also may need to provide some support with the hands, rather than like swaddling uppers versus lowers. But I think it's just making adaptations as you see fit, as a healthcare professional, to allow them to have some free movement, but not to get overly stressed by it.
So maybe the confusion was just when you were saying like change the diaper. I think people were thinking maybe it's unobserved, right? So obviously you're saying it's like you pace the baby and you provide it and then modify based on the baby's response. Is that fair?
Yes, yes. So you're
Great.
still in the room with them, and you can kind of keep tabs on.
It's not like I open you up, baby, and then like, good luck, I'll be back in 2 minutes.
No, yes.
Awesome. So someone, Kathleen, so Kathleen, I'm asking your question here. So that they did a lot of research about cycled lighting in their unit last year. They didn't interpret it for babies less than 32 weeks should be in dim. They did require lights on for cares and some other modifications. They were wondering if you could share your reference on the continuous dimness before 32 weeks.
Yes, I can. Can I send that to you afterwards?
Sure, and then maybe we just can link it in the resource page.
Yes, and so they're cited within the integrative review, but I can actually pull them up separately, and then I can share them with you.
Okay, great. Or Kathleen, if you want to chat in your email address, we'll copy the chat and we can forward that too. As you could probably imagine, people love your parent book, and they're wondering, at this point, I think I could answer this question that it's only in English, but is there plans for Spanish or other languages in the future?
Oh my goodness, if there was someone who would translate it, that would be awesome. But I don't have any immediate plans on it, just because I am unfortunately not bilingual. But it's something that we could look into in the future if there was interest.
So if somebody wants to write a grant and give the grant to Bobbi's lab so she can work on that. That's someone's task out there.
Or if you speak another language and you want to translate it, that would be wonderful.
Awesome, great. So Car Davis, who asked that question, there you got it. Someone asked about, can you give and I'm not quite sure, this is from Paula, a little bit more information about sensory support for the 34 to 35 weekers. So I'm not sure if maybe you passed through that slide really quickly, or if there's anything specific around this late preterm group for sensory support, or if you have any comment to that question.
Yeah, so the sensory exposures within the sense guideline are really, so like it starts out being very, very low when the baby is extremely immature, and then it increases over time. So I think I paused on the 32 to 33, and then I paused again when I was talking about the closer to term age. So the 34 to 35 would just be, you know, it's a little bit less than the others. Actually, I could go back, I suppose. Let's see. You are still able to see my slides, right? So
yep, I see 'em.
For tactile, providing at least 3 hours of positive touch with choices, providing a minimum of 2 hours of positive sound, holding the baby as often as possible, cycle gliding is appropriate at that age, and then they would have the unrestricted movement opportunity during each diaper change, and then rocking for 3 to 7 minutes. Hopefully that answered it.
Yes, absolutely. Oh my gosh, now 5 more questions just popped up. Let's see, let me see if I can pull a few of these out. We're lucky enough, so this is from Megan, we're lucky enough to have a music therapist. We're curious if any music therapy research was included. Music therapy has been vital for the auditory portion. So
yes, so I completely value that the music therapy community has actually come out with some great research that they've contributed within this domain. And I love speaking with music therapists because I feel like they approach things from a very different way than other therapists, PTs, OTs, speeches do. And it really, I think, helps to expand our repertoire. So when we did the integrative review, we were not specific, like it had to be a nurse researcher or a music therapist researcher or a therapy researcher. It was just, is there literature within this domain for this specific construct? So for example, auditory exposure. So it would have included any of the music therapy literature that was within that time period. If there was a developmental outcome, if it was within the last 20 years, whether it was done in a level 2, 3, or 4, and not with a specifically designed low-risk sample.
fantastic. One kind of practical question Megan also asked was, how did you measure for your interventions the amount of time that each stimulation was conducted?
Oh, that is a great question. So within the sense intervention, there are bedside logs. And so the bedside logs go down each week for our study babies. And the parents track basically what they do. And so it has a place for them to say what stimulation they did, for how long it was. There's also some for the healthcare professionals. So like if the therapists come in and do an intervention, they can also track that. And then there's one for the sensory support team. And so then cumulatively between those 3 things, we hope that we're meeting our minimums that we've established with the sense intervention. So we track it with logs, and then we also do a couple fidelity checks throughout where we do video recordings for a 24-hour period, and we also do the LINA to see if in fact the sensory exposures are matching up to what we have with our logs.
Great. And kind of a dovetail to that is, so you had the minimum times for, say, skin to skin, but did you actually is your practice to encourage longer periods of time for any of the particular interventions?
Yes, and that's an interesting question, because like you look at what they're doing in Sweden and it's just phenomenal, right? I mean, they get parents to do skin to skin for like 22 hours at a time. It's just awesome. We have established minimums. And so parents are encouraged or welcome to do as much as they want beyond that minimum. It's just that we really strive to at least get to that point where we're at the minimum of exposure.
Great. Let's see. Oh gosh, there's just so many great questions. I'm trying to read them all and all of that. So Kathleen asked about, in your unit, do you have a developmental care specialist or an early interventionist that works with your infants?
That is a good question. So I do research only. I do clinical research, so I'm down there. So maybe I'm not the best person to
So
ask
maybe.
that, but I don't think so based on what I know. I do believe that we largely use occupational therapists, physical therapists, and speech language pathologists. We have a pretty dynamic team, multiple different people that go down and serve the needs of the infant. But I don't believe we have a developmental specialist / early interventionist aside from that team.
Great. I know it's really one of those kind of things that it's variable from unit to unit, right? And many times budget related. Let's see, gosh, there's so many questions about kind of the use of the booklet and all of that. So I think what we'll do is we'll post your outline that you provided that has your contact information, and then people can ask specific questions around kind of the legalities of creating the license with you guys to reuse it and all of those things. So people are asking about the poem and about some of the just how do we reprint it at our hospital and all of that. So I think that would be the best way. Would you agree?
Yes, and then just to kind of dovetail off of that, so right now we are offering it at cost. So like we're not making any kind of profit on it, but unfortunately it does cost like print stuff and get people to be paid to do that. But then once you get it, and for your hospital, you basically have a license for it, and then the materials are such that you can print them off as many times as you want. So you can make as many booklets as you want to be able to distribute within your own hospital.
Fantastic, fantastic. One person asked about the use of mobiles, I'm guessing for visual. So is that something that you've used in the NICU, but just not in this study? Or how do you where did mobiles fall in your lit review?
Yeah, so that is a really great question. I won't say that we don't have mobiles in our unit, because we do. But as part of the SENSE guideline, it's all evidence-based, and there was no evidence to support the use of mobiles or visual stimulation like with target cards or balls or anything that you really put in front of the infant. So we did not make that part of visual exposure within the SENSE guideline. But what we did is, starting at 36, and this is also kind of keeping in mind like family integrative care and Graven's great work, that really these visual exposures shouldn't happen until closer to term equivalent age anyways, is that in that later time period from 36 to 40, that you can do visual stimulation, but really focusing on trying to get the parent to engage with the infant. So, mother's face, father's face as the visual stimulus, rather than specific visual exposures.
Fantastic. So there's a question around, oh gosh, I just lost it. Oh my gosh. Oh, two questions around the method of infant massage. Did you stick with a specific type of infant massage for all infants who receive massage? Do you guys have a standard?
That is a really great question. There are lots of different ways that you can do massage, which can be a little bit confusing, I guess, at best. But we chose to really use what our therapy department uses as their traditional way. They hold a massage class, I think like once a month for families. And so basically we just use the exact same practices that they use. But I also recognize that there's probably different ways, not just massage, but the M technique. You can use a whole other different, there's a lot of different ways that you could potentially implement the massage piece.
Fantastic. What about vestibular stimulation? So this person was commenting, and someone else did too, so I'll see if I can maybe combine two questions, is just when the unit is so busy and nurses are busy with emergencies or short staffing, and there are gaps in the times that therapy can come, and they don't have a SENSE team, how would you envision that units who don't have those things could do the rocking? Would you use swings? Would you use chairs? Or would it only be human guided?
Yeah, so the SENSE intervention is definitely only human guided. How we've been able to achieve it is coupling these things together. So the baby has to come out of the bed and be orally fed. And so maybe you do oral feeding and then you spend some time right after the feeding where you're doing maybe it's like 3 minutes at that post-menstrual age. You do 3 minutes of rocking before you then get them back nestled into the bed space. So that's how we've achieved it, and the SENSE guideline doesn't include the other things just because there wasn't evidence to support it.
And can you remind us what age you recommended the gentle rocking begin?
Ooh, that is a good question. I would have to look back. I want to say it's starting at 34, but I'm not quite sure. I would have to look back.
No worries. And some people were asking how you've measured the lux for the light exposure. Yeah,
so there are devices that you can buy online, and some people will use applications also on iPhones. What I understand though is that when you use the lux and the decibel recorders on an iPhone, they're not quite as reliable as the other devices that you can get. But we've purchased ones, I think they were like $65 online. And it's just really informative. So like being able to tell what the lux is if you're in a shaded area versus an open area, when the blinds are open or when they're closed. So that's kind of what we've used it for. We've just bought one of the ones online and then gone down to the NICU and kind of experimented with it until we were able to achieve the lux that we wanted.
Fantastic.
And then same thing with the decibel recorders. Prior to us doing the SENSE intervention, they really don't allow tape recorders within our unit. And so that's kind of been a new and a little bit of a culture shift. So with the tape recorders too, we use a decibel recorder, and we make sure that it really is at 45 decibels, which is really, really quiet. It's not very loud at all. And then we tape the volume down so that it can't be modified. Some parents have ripped the tape off and jammed it back up, but it is just kind of like an extra little reminder that, it needs to stay quiet for the baby.
Fantastic. Oh gosh, there's still a few more questions, so I hope you have some water nearby. We'll keep going, I guess. And again, we totally know some of you need to hop off, but I mean, there's just so many great questions, and Bobbi, you're such a great wealth of knowledge. So we'll just keep plowing through them. They're going. So maybe I missed it, but maybe you can remind us for the enrollments. Did you guys have a gestational age requirement for the babies who were enrolled, or was it any gestational age? Was it preterms and term babies?
That is a great question. So for us, for our trial, we are taking babies that are born less than or equal to 32 weeks gestation at birth. As we send out these materials, though, we actually give like pointed questions just to help hospitals ascertain like how they might want to use it. So other hospitals within their own culture might want to do something differently. Maybe they're just going to do it for late preterm infants, or maybe they want to try it with NAS baby. I mean, different hospitals may have different applications of it. So it's not that it's hard in stone, but the trial will be on babies born less than or equal to 32.
Okay, because that was actually, you perfectly answered this person's exact question, which is, did you address any NAS babies' needs with this SENSE intervention?
And no, so it's specifically designed for preterm infants, not really for NAS or for HIE or any other specific population, but maybe that's somewhere that we can go in the future.
Yeah, I think certainly the opportunity, right, to look at these interventions with other populations makes sense. So I can totally see why people are asking. So the answer for the study is no, but people, when they choose to maybe implement this, could choose their own populations that make sense.
Yeah.
Awesome. Okay, let me see a couple more. There is a recording of this, someone asked, and there is an outline which we posted in the chat area if you want to download now, and we will post that on the resource page. So if people are watching the recording, they can do that. And because it's a research study, the whole slide deck is not available, but an outline is, and how to get more information. So this person is asking about, just some ideas, and maybe this comes, like you said, with your implementation strategies that you provide to your new collaborators, really about how do you get a big group involved in this? Like, what would be the steps they would have to do? Do you have any suggestions for that from places that are going to implement this?
How to get other people involved in it. So we are also coming up with just like a short intro video, where like in 15 or 20 minutes, it'll hopefully give an overview of like what's needed to be able to do it. Like that you need the sense administrator, you need parents, you need basically the team to be on board with it. So that might be like a good place to start, but I think also it's just, I don't know, for me, like evidence speaks volumes. And so, you know, if you pull up the evidence is supporting these sorts of things, it can go a long way. So like pulling up the integrative review, and this sense guideline consists of all of these interventions that are outlined within the integrative review. And then hopefully we'll have more evidence by the end of the year, knock on wood, that can then contribute to, I don't know, people may be feeling more convinced that this is a good thing to implement. I think when the focus is on the babies, that this is, you know, it's not about trying to make people's jobs harder or adding yet another thing into the NICU environment, but it's really just about trying to support the neurodevelopment of these infants who are just, you know, they're just starting their lives. Like they have the rest of their lives even after the NICU hospitalization. I think when we focus in on that we're really trying to improve health and well-being long-term, that it really helps people get on board as well.
Fantastic. No, I think that's great. There are some other really kind of specific questions that I think maybe people could reach out to you and your team and ask about maybe some of the products that you use. And there's some questions around kind of why you elected not to have your sense support team holding as students, those kind of things. So I'm not sure if that feels relevant to the whole group. Do you want to answer that?
Sure. I can answer that because it's something that, like, even as I think about it, you can see me kind of like squirming in my chair a little bit. I don't know, with therapy, you know, being in the NICU, it's considered an advanced area of practice. And so you have to have this advanced skills and training that go along with that. And with that, you learn all the little nuances. So it's not just like having to deal with the NICU environment, but then it's the things about the baby too, all of the medical equipment that they have, and how when you change the position of the baby, even how you might have some kind of effect. And so the minute that you're talking about holding, you have the potential for neck flexion that can be problematic in terms of air exchange, and a whole host of other things that maybe the student isn't like experienced enough to be able to be preventative in nature, and certainly isn't experienced enough to know what to do if there's like an aftermath or some kind of consequence of the way that they were holding. So we've just decided that for now, it's best that they don't. I won't say that we haven't had students holding, because we have in isolated cases where we did a little bit of additional training with them, but we just didn't feel like they had enough experience to feel completely comfortable across the board with it.
I think that's probably a fair question. I mean, because I think it's probably challenging because some of the babies were really small in your study. And so I guess maybe some people were thinking, you know, well, we might allow volunteers or cuddlers to come into our units and they hold babies, and these students have had even more education than them. So maybe I think maybe that's where people were getting confused on that.
Yeah, and we've had the same thought as well. And there wasn't anything like specific that happened that made us feel that way, but it was just maybe always a feeling of just feeling like they needed a little bit more experience and training to do that. And really, when cuddlers come into our unit, at least, they're really holding more of those babies that are closer to term age, not really the young ones. So anyways, yeah.
So one final I'll do here, since we've gone really, I'm just so grateful for all of you hanging on here. This is some great conversation. So when you did the touching interventions, so obviously parents aren't using gloves, but what about your sense team or the nurses or even your other therapists? Do they provide hand on skin, or do they use gloves?
We do not use gloves unless the baby's on isolation precautions. We don't use gloves during our interactions. It's just hands. I also don't, but like if we're doing gentle human touch, for example, we would be doing it over whatever it is that they're in. Like we don't unswaddle them and jostle them around. It's really more supportive, like giving a little hand hug in whatever it is that they're in. Unless they're showing a need to like have a change, we don't change that up.
Awesome. And then there's one final question around lighting, but I think you said you would share maybe the references on lighting. So maybe we can include that on our resource page. And that way, in case there's other people asking more about the cycle lighting research and when the ages and then also the ranges of lux that you've recommended for your study. So we can kind of put that out there.
So I'll definitely share articles that we have when we supported it, but there was also a focus group discussion and some concern about going. So I think one of the recommendations in the literature is up to 250 lux. So ours is lower because largely our team wanted it to be a little bit on the lower side, feeling like current recommendations within the literature maybe were a little too high. So that's why ours is a little bit different from others. They erred on being a little bit more conservative.
Okay, fantastic. Great. Thank you for clarifying that too.
Thank you,
Kathy
Bobbi.
Bush.
This amazing webinar was brought to you by DandleLION Medical, and as Kathy said, thanks all of you for hanging on through all the questions. They were really great ones, and we are so thrilled that we have an expert like Bobbi that is part of our webinar series. I'm sure most of you who hung in here want to receive your free CE. In the chat area, you will find a link to the webinar evaluation. If you click on the evaluation link and fill that out, you will then be directed and get your CE certificate. If you're watching the recording, please go back to the email you received with the link to the recording and click on the link to the evaluation form. If you don't have time to fill out the evaluation right now, or if your hospital has blocked access, again, you can get the link off the recording. Now, if you're viewing as a group, each person must log into the evaluation form to get the CE. We hope you will visit the DandleLION Medical website for future webinars and also links to the recordings of our previous 3 years of webinars that are all still active and available for continuing education credits. We also hope that you'll like us on Facebook or LinkedIn to be the first to find out about what's new at DandleLION Medical. We announce our webinars there and any other product information. We are really pleased that some of the positioning aids and other things that were used in Bobbi's presentation were DandleLION positioning aids especially, and we'd like to think that they are a very positive part of the baby sensory experience. So we hope you will visit our website to learn more about our positioning aids. So again, thank you all for your participation, and many thanks to Bobbi for another great DandleLION webinar. Thank you, everybody. Have a great rest of your day.